everyone. So it's about 7:05, and I see there's a fair number of people logged in as well. Dr.
So Tala,
Nagamalesh,
I think that is a basic dysfunction. Everybody is mute.
Yes. All right. So on behalf of the society, can I request everyone to mute their mics, please? Can I please request everyone to mute their mics? Yoshi, can you please mute everyone else's mics, please? All right. So on behalf of the Society for Heart Failure and Transplant, this is the first webinar of the series of webinars that's going to be coming up for the next year. Dr. Aditi Singhvi, who with me, who's also an executive committee member in the society, along with me, we have curated a series of webinars along with support from all the leadership from the Society for Heart Failure and Transplant. The idea is to talk and discuss on focus topics related to advanced heart failure, advanced lung failure, cardiac transplant, and lung transplant. The first topic that we will be discussing today is primary graft dysfunction after cardiac transplant. We have two speakers from the SIMS hospital team in Ahmedabad. The initial case presentation will be made by Dr. Meet Kansagra, who's a second-year DNB cardiac anesthesia student with the SIMS Ahmedabad team. Following that, we'll have a formal presentation on the topic by Dr. Chintan Sheth, who is also a cardiac anesthetist and holds the post of the co-director of the cardiac transplant program at SIMS Hospital, Ahmedabad. Joining us shortly will be our moderator, Dr. Nagamalesh, who I'm sure everyone knows is a senior cardiologist and the director of cardiac transplant and the mechanical circulatory support program at Aster Hospital, Bangalore. We'll keep plenty of time for discussion at the end. Hopefully in 40 minutes, Dr. Meet and Dr. Chintan would be done with the case presentation as well as the topic discussion. And at the end, we will keep an open forum for discussion. The discussion will be led primarily by Dr. Nagamalesh, and Dr. Aditi and I will chip in whenever required. For all the other listeners tuning in, please make sure if you have any questions, please type them in the chat box, and Dr. Nagamalesh and Dr. Aditi and I will try to get them up for discussion. Again, sincere request to all the listeners to keep their microphones on mute so that the audio from the speakers is clear. All right, I think the stage is set. Dr. Meet, over to you.
So, thank you very much, Dr. Tala, for very kind introduction, and good evening, one and all. So, and I think this is very fantastic initiative to start the focused online meet so everybody can attend, and it's really, really good. I really appreciate that. So, we'll start with the case presentation by Dr. Meet.
Good evening, all the seniors. Today I'm presenting a case on primary graft dysfunction. So basic history is 42-year-old female, weight is 42 kg and height is 150 centimeter, non-case of diabetic and normotensive, and non-case of postpartum dilated cardiomyopathy since 4 years, and frequent hospital admissions for the heart failure in last 6 months. So on echo, there is a severe LV systolic dysfunction. LVF was around 15%, severe RV dysfunction, TAPSE was around 12, and severe MR, moderate TR, and RVSP was around 45 with dilated IVC. On right heart, so we did right heart catheterization, And on right heart cath report, initially TPG was around 9, and after midline bolus, 50 microgram per kg over 30 minutes, and with oxygen support of 4 liter per minute, it was same of 9. Then we start the infusion of milrinone 0.5 microgram per kg per minute and levosimendan 0.1 microgram per kg per minute for 4 hours with oxygen support, and TPG was came down to 7. Same as with PVR, initially it was high 5.29, and then after milrinone bolus it was 3.75, and after infusion for 4 hours it came down to 2.59. So we accepted that patient for the heart transplantation as PVR is less than 3. On blood investigation, only abnormal blood investigations were reported. That serum bilirubin was 2.5, SCPT was 66, NT-proBNP was 5,825, and HbA1c of 7.15. On PRA, penile reactive antibody HLA class 1 and class 2 both were negative initially. Regarding donor details, donor was 37-year-old male. Cause of brain death was road traffic accident. Is from Surat, Gujarat only. Weight is 62 kg and height is 167 centimeter. Predicted heart mass donor to recipient was is 1.47, and he is on minimal dose of vasopressin and noradrenaline. On echo and visual inspection of the heart, that heart looks good, so we accepted that heart for the transplantation. Cardioplegia solution was used was HTK, and static cold storage was maintained. Total ischemia time was 3 hours and 27 minutes. On CDC cross matching, LCM was negative, score was 1, and again PRA was negative. HLA class 1 and 2 both were negative. LCM and DSA both were negative. Intraoperatively, induction immunosuppression, injection basiliximab 20 milligram IV was used, and methylprednisolone 1 gram IV was used. After transplantation, immediately after opening the clamp, there was severe LV and RV systolic dysfunction. LVF was around 35%. So we decided to give rest on CPB for 1 hour. After 1 hour support on CPB and optimization of inotrope, LV and RV function was improved, but there is some amount of RV dysfunction. LVF was around 50 to 55% with mild TR, and RVSP was around 45. And then shifting the patient to the ICU, after 4 hours, there is severe biventricular dysfunction with moderately severe TR and moderate MR. And there is severe RV systolic dysfunction. RVSP was 22 and CAP of 12, so PA pressure was around 42 per minute, 42 mmHg. And she is on very high dose of vasopressor and inotrope. Despite of that high dose of inotropic and vasopressor support, cardiac index was around 1.6, and she is having persistent metabolic acidosis. So now the diagnostic part and management part will be taken by Dr. Chintan Seth, sir.
Yeah. So this was the history of the recipient and donor, and this is not the uncommon post-heart transplant. So initially LV was little bit down. We gave support on the CPB. We optimized the endotropes. LV become 50 to 55%. We shifted that patient to the ICU in the stable condition. She was stable for first 4 hours in the ICU, and after 4 hours there was low cardiac output state and hypotension. We checked the echo, and this was the echo that patient has now severe LV dysfunction associated with RV dysfunction, and there was moderate MR, which was not there before. So this happens is almost in 10 to 30% of the patients post heart transplant. And if you see any time low cardiac output state within first 24 hours after the heart transplant, it's called early graft dysfunction. And early graft dysfunction can be because of primary graft dysfunction, or it can be because of secondary graft dysfunction. So in 2014, Koshabigawa and team has given very clear-cut definition for the primary graft dysfunction, which was published in the ISHLT journal. So there are 4 prerequisites will be required to label any patient post-heart transplant as the primary graft dysfunction. So first is the ventricular dysfunction, either single or biventricular of the donor graft, which fails to meet the circulatory requirement of the recipient, means that low cardiac output state. Second, preload and afterload should be normal. So it's actually the inotropy failure. It's nothing to do with like hypovolemia or high afterload or low afterload vasodilation. Basically, a problem with the inotropy. Third is it should occur in the first 24 hours. So primary graft dysfunction we can label only occurs in first 24 hours. And this is very important, that absence of the secondary causes for the graft failure. So like hyperacute rejection, in this case, we can rule out hyperacute rejection because patient's LCM was negative, DSS were negative. So rarely it can cause the acute rejection like this. Second cause for the secondary graft failure is the high PVR related RV dysfunction. In this patient, there was some RV dysfunction, but main problem right now is the LV dysfunction. So we can rule out that also. After coming of the CPB, we checked all the anastomosis. There was no any kinking or narrowing of the anastomotic site. And on echo, we have ruled out that there is no bleeding and cardiac tamponade. So when there are no any secondary cause for this type of LV and RV failure, we can label this patient as the primary graft dysfunction. So in same, ISHLT has given the very good grading for the primary graft dysfunction. So for left ventricle, when we call it left ventricle, when LVF is less than 40% and pulmonary capillary wedge pressure is more than 20. So as we all know that when there is LV failure, there will be increase in the LA pressure, there will be MR and PCWP will go up. So LV primary graft dysfunction again divided into mild, moderate and severe. Mild is when you can just manage with the inotropes. Moderate, when inotropes are not enough to maintain the cardiac output and body's demand, then we have to add the IABP to that, then it's become moderate. And even with optimal of inotropes, IABP, still there is low cardiac output state, we have to go on the mechanical circulatory support like ECMO or LVAD, and then we can call it the severe primary graft dysfunction of the left ventricle. For right ventricle, as we all know, in right ventricle, CVP will go up because of increase in the RV and diastolic pressure. There will be tricuspid regurgitation. So CVP will be more than 15. But here, as LV is the normal, pulmonary capillary wedge pressure will be less than 15 mmHg. The pulmonary capillary wedge pressure is the differentiating point between the LV and RV primary graft dysfunction. In LV, it will be more than 20. In RV, it will be less than 15 mmHg. Rest all things are same, like cardiac index is less than 2 liter per minute per meter square. TPG less than 15 mmHg, because if TPG is more than 15, then we can label it the RV dysfunction secondary to high PVR, and requirement of right circulatory assistance will label it as a severe RV dysfunction. So RV is not graded as the mild, moderate and severe. It will be just RV primary graft dysfunction. So what is the mechanism? So mechanism is the ischemia reperfusion injury. It's the mechanism for the primary graft dysfunction. But donor heart, if we see the donor heart, from the time of the brain death, it will come to the lot of trauma. So first and foremost, when there is the pontine ischemia with the brain death, there will be sympathetic storm, and because of that, there will be profound release of the adrenaline and noradrenaline in the system, and that can cause the increase in the afterload. Vasoconstriction increase the afterload, then increase in the afterload will damage the LV. Subsequently, when there is this like spinal cord shock, it causes the profound vasodilatation and hypotension, and that decreases the coronary perfusion pressures and further damage the LV. So such already damaged LV, when is predisposed to ischemia and then further reperfusion, it will cause the primary graft dysfunction. So during ischemia, what happens? There is lack of oxygen, and there will be lactate, increase in the lactate and increase in the H plus ion. H plus ion will be replaced with the sodium calcium pump, and there will be increase in the intracellular calcium. Whenever there is reperfusion happens, there will be oxygen, and there will be further increase in the intracellular calcium. And then oxygen, after the ischemia already damaged heart, when there is oxygen, it will generate the oxygen-free radicals and inflammatory cascade. And ultimately, it will cause the reperfusion, induce hypercontractual state of the myocardium, contraction band necrosis, and LV and RV become stiff, and ultimately hypercontractual mediated sarcolemmal rupture. So this is the hallmark. So stiff ventricle, which is even systolic dysfunction also and diastolic dysfunction also. So incidence, if we see, it's the 10 to 30%. It is the still today also it is the leading cause of death after the transplant. The first 30 days, short-term mortality is 17 to 37%. Long-term mortality is 6.3 to 31.9%. And patients, recipients who develop PGD, they have future risk of developing the acute rejections and cardiac allograft vasculopathy. So there are many risk factors for the primary graft dysfunction. It can be donor related, procurement related, what kind of cardioplegic solution we are using, how is our preservation method, recipient related factors, and surgery related factors. Among all this, the list, the five which all are the highlighted in the red fonts are the many studies have found that these are the common factors, risk factors for the primary graft dysfunction. One is when recipient is on the mechanical support, like on LVAD, or if recipient is on the amiodarone. When ischemia time is more than 4 hours, when we have used the undersized donor by more than 30%, and when there are high blood transfusion in the recipient. So these five are the major and common risk factors for the primary graft dysfunction. And radial is the very novel score which is given in 2011. So radial is the acronym, it stands for right atrial pressure in the recipient more than 10 mm of Hg. That suggests there is some evidence of RV dysfunction initially. When recipient age is more than 60 years, when recipient is having diabetes, recipient is inotrope dependent, and when donor age is more than 30 years and ischemia time is more than 4 hours. So more the score, more is the risk for the primary graft dysfunction. There are some biomarkers which are associated with the risk for the primary graft dysfunction. So in donor, if there is high level of procalcitonin or troponin or BNP in the donor high, that all can predict the risk for the primary graft dysfunction. But none of these are so sensitive and not so specific for the primary graft dysfunction. So now management point. So as we are told, LV for the LV, it can be mild, moderate, and severe. And if it is the mild LV primary graft dysfunction, it is very common. I can see it can happen almost 40 to 50% of the patients. So, this is what happens when we open the initially clamp and observe the LV. It will be always most in 50% cases. It will be like EF will be 25 to 35%. And when we optimize the inotropes, when we give the supports to that patient, that LV improves after the giving the support. So our dictum is whatever the ischemia time, 1/3 of the time we should support the LV on the CPB with optimization of the inotropes and mean perfusion pressures. So inotropes of choice are milrinone, but many times we cannot start milrinone because of already patient is having hypotension. So in that milieu, we start the dobutamine. We always start the adrenaline, and levosimendan is also, there are few studies which has shown that levosimendan, when patient can tolerate, if there is not much hypotension, if we can the levosimendan, it is very useful and it can prevent the mechanical circulatory to going on the mechanical circulatory support. So levosimendan is also good inotropic choice if patient can tolerate to further aggravate the primary graft dysfunction. And vasopressors to maintain the perfusion pressures as per the systemic vascular resistance index. So all these patients are put the CCO Swan-Ganz catheter, and we are monitoring what is the systemic vascular resistance index. So, and in this patient post heart transplant, vasopressin is preferred over the noradrenaline, as vasopressin just increase the SVR and it will not increase the PVR because pulmonary vasculature doesn't have the vasopressin receptors. So when we use vasopressin, it will not increase PVR and it will not cause the RV dysfunction, but it will increase the SVR only, and that increase in the SVR will improve the coronary perfusion and improves the LV and RV function. If inotropes are not sufficient, after optimizing all the inotropes, preload, afterload, and still there is the low cardiac output state, we have to insert the IABP to that patient, and IABP will augment the cardiac output by 5 to 30%. And when we have to insert the IABP to such patients, we label it as a moderate primary graft dysfunction. So in our case, what we have done, so as we have seen that we have optimized all the inotropes, still patient was in low cardiac output state, cardiac index was 1.6 to 1.8 liter per minute per meter square. So we inserted IABP and associated with nitric oxide, and all inotropes are going on. So in our case, after 36 hours supports on IABP, we can see that LV has improved. So here you can see the LV is around 40 to 45%. MR, which was moderate, it is now just trivial to mild. And there is some evidence of RV dysfunction because this patient has high PVR initially. So there is some evidence of RV dysfunction with grade 2 to moderate TR. So after that, patient was hemodynamically stable, in good condition, pouring good amount of urine. On CPAP, ABG was fine. So we extubated the patient after 40 hours. And after 48 hours on IABP support, we can see that LV has become complete normal. It is 60%. Now there is no MR, which was before, it was moderate when there was primary graft dysfunction. there is some evidence of RV dysfunction and moderate TR, and this TR will take almost like 1 month to become mild. So patient becomes stable. We discharge the patient in the stable hemodynamic condition, and yesterday only patient has finished the 3 years post-heart transplant. She is doing absolutely fine. So now suppose we have inserted IRBP, still patient is in the low cardiac output state and not meeting the not meeting the circulatory demand of the recipient. Then we call it the severe primary graft dysfunction, and that will be treated by the mechanical circulatory support. It can be either temporary beds, so we can put the Centromec, either if only RV isolated RV primary graft dysfunction, we can tackle with the RVED, then maybe LVED, or if both, then we can use the BiVED, or it can be VA ECMO. ECMO can be central or peripheral. So now there is always a debate that what should be inside, whether we should go for the VA ECMO or VEDS. So this is very nice study by the Takeda et al. And what they have done, yeah, I cannot see the screen actually. Yeah, so in 597 heart transplant patient, in their series 44 patients, 7.4% patient developed severe primary graft dysfunction. So in that, 17 received LVED and 27 received VA ECMO support within 24 hours after transplant. And what their results were, implantation of the temporary VED was associated with longer cardiopulmonary bypass time. It requires longer support. There was higher incidence of bleeding with the VEDs, and there was higher incidence of renal failure requiring the renal replacement therapy with the VEDs. So overall hospital mortality was also high with the VED, like 41%, VA ECMO 19%. There was higher chances of successful weaning with VA ECMO, so 24 versus the 10 patients. And 3-year post-transplant survival also higher with the VA ECMO. And what they have concluded, for severe PGD, support with VA ECMO appears to result in better clinical outcomes compared to the VED. So they have very clear-cut mentioned that VA ECMO is better than the VEDs for the primary graft dysfunction. Now, okay, we have to put the ECMO, but now when? So timing is very important. So early versus late ECMO initiation. So very wonderful study on that. So 362 patients, in that 38 developed a severe PGD who were treated with the VA ECMO, and they were divided into two groups. One is the conservative group and one is the prompt group. So in 18 patients, the conservative group, and 20 in the prompt. So what is prompt or early approach? So ECMO initiation in operating room only. So when to initiate ECMO? So when mean arterial pressure less than 60, when CVP more than 16, cardiac index less than 2.2 liter per minute per square, despite of use of more than 2 high dose of inodrops and 2 high dose of vasopressor. So when this is the condition in OR, initiation of the ECMO in OR itself, that's called the prompt approach. And if you see the results, that medium time to initiation of the ECMO in prompt group, it was 1.95 hours of developing PGD, while in conservative it was 7.26 hours. In hospital mortality was 5% in prompt group, while 28% in the conservative group. And post-transplant survival at 1 year also significantly better, 90% in the prompt group compared to conservative group. So what they have concluded, early and aggressive initiation of ECMO for patients with severe PGD results in excellent allograft recovery and suggests a decrease in mortality. So treatment is VA ECMO, and it should be prompt and early instead of waiting for the 6 to 8 hours in the ICU and then persistent acidosis, end organ damage, and then we initiate the ECMO. They have poor results compared to we promptly in OR itself initiate the ECMO. Now there is one more debate: central versus peripheral ECMO. Which ECMO should be inserted? So central V ECMO advantages are it's a faster installation. This is the most important advantage, that it gives the antegrade flow, and it increase the increased LV afterload. So this is when we insert the peripheral V ECMO, there will be increase in the LV afterload, and then increase LV afterload further damage the already damaged LV by the primary graft dysfunction. So here we can prevent the increase in the LV afterload, and even we can we can prevent the LV distension also, because we can on central ECMO. We can, when we are inserting the central ECMO, we can directly evaluate the LV, whether it is properly decompressed or not after initiation of the ECMO. And if LV is distending, it is very easy to put the LV vent. Either we can put the LV vent to the right superior pulmonary vent or through the LV apex. And hybrid approach, like shown in this figure here, that we can put the tunneled cannula then chest can be closed and patient can be mobilized also. So these all are the advantages of the central VA ECMO. Disadvantages of central VA ECMO: infection, bleeding. We all know when we have the central cannula in place, definitely there are chances of bleeding. There will be reoperation to decannulate and difficult mobilization with the central VA ECMO. Peripheral VA ECMO advantages: chest can be closed and there will be decreased risk of infection and bleeding. But many disadvantages like retrograde flow, so it increases the LV afterload. And when there is increase in the LV afterload, there will be LV distension, and that causes the three problems. One, LV distension will cause the increase in the LV wall tension and ultimately cause the arrhythmias. There will be, because of LV distension, there will be mitral regurgitation, pulmonary edema, and there can be pulmonary hemorrhage. This is very, very common when we have the peripheral VA ECMO and increased afterload. And when there is LV distension, there can be stasis of the blood in the LV, and which can cause a thrombus formation in the LV. If LV is distending on the echo and peripheral VA ECMO, we have to decompress the LV by either putting the IABP or direct LV vent by doing the mini thoracotomy, or we can shift the patient to cath lab and put the percutaneous LA drainage cannula, or we can use the impella to decompress the LV, which called the ECPella. When ECMO and impella combined, it's called the ECPella. Then one more problem with the peripheral VA ECMO is the Harlequin syndrome, north-south syndrome, we all know, which causes the differential cyanosis. Then limb ischemia can happen. So, but whenever there is the distal perfusion cannula is there are less chances, but still many times this cannula can be blocked or kinked, and we have seen patients have distal limb ischemia with peripheral VA ECMO. And sometimes with this configuration of peripheral VA ECMO, we cannot provide the adequate circulatory support. So central versus peripheral VA ECMO, there are some studies, and actually study has found that central VA ECMO with tunneling of the cannula and closure of the chest could be a better option patient with primary graft dysfunction after transplant. So central versus peripheral, I think it depends upon the first is the central centers experience, preference, logistics, whether it's available or not, what are the logistics we have available. And second is the how is the condition, whether if it is happens in the, if severe PGD happens in the OR, then I think obviously central VA ECMO is the treatment of the choice. Then second thing, how is the LV function? If LV is hardly 5 to 10% not ejected, not contracting, then putting the peripheral VA ECMO and increasing the afterload and further damaging LV is not a good option. In such case, central VA ECMO is the better option. So, and how emergency it is, because peripheral VA ECMO cannulation may require some time. Like central is more emergency, we can start the central ECMO. So in emergency also central VA ECMO, and overall also if we see, because it provides an integrate flow, central VA ECMO is better over the peripheral VA ECMO. Now, if there is isolated RV primary graft dysfunction, incidence is 40 to 45% of the total primary graft dysfunction. So treatment is first same inodrops, optimal medical therapy for the right ventricular primary graft dysfunction. So obviously increase the RV contractility by starting dobutamine, adrenaline, milrinone. Adrenaline is a very good inodrop when there is severe RV dysfunction, because then adrenaline can only give the good kick for the RV to overcome the high PVR or generate the cardiac output. Then decrease RV afterload. So by starting the inhaled nitric oxide, milrinone, which is a good inodilator and good pulmonary vasodilator. Sildenafil, we can have IV pulmosil, or even afterwards we can start the oral sildenafil, and ambrisentan we can use. Then RV friendly ventilator strategies like low PEEP, low tidal volume, hyperoxia, keep little bit high PO2 goal, and low normal PaCO2. Optimize RV preload. This is very, very important. So target CP should be 10 to 12 ml of HE. Most of the time when there is RV primary graft dysfunction, RV dysfunction CP will be like 18 to 20. That will further cause the RV volume overload and further damage the RV. So whenever such condition happens, early diuresis, like and or if required dialysis with CRRT or slide should be instituted. Then maintain RV coronary perfusion pressures. So here, as we have discussed, if we find is the patient is vasodilated, SVRI is low, then we prefer vasopressin over the noradrenaline. So vasopressin is a wonderful choice of vasopressor when there is the RV dysfunction. Maintain sinus rhythm. If patient is not still in low cardiac output state with after the optimal medical therapy for the RV, then next we can put the IABP for the RV support. So IABP is not only support the LV, it has very good effect when there is RV dysfunction. So mainly two things. one thing, it increases the RV coronary perfusion pressure and improves the RV coronary supply. And second and more important thing is it improves the end organ perfusion, especially kidney, liver, and gut. So as we have discussed, because of RV dysfunction, there will be high CVP. And if you see the perfusion pressure of the any organs like kidney, liver, or gut, is the mean arterial pressure minus CVP. Now, when patient is in shock, MAP mean arterial pressure will be low and CVP will be higher in RV dysfunction. So perfusion pressure of all these target end organ decreases. So when we insert the IABP, it improves the mean arterial pressure. And because of that perfusion pressure, the kidney improves and we start diuresis. So many times we have seen before putting the IABP, urine output is like 15-20 ml per hour. And after 1 hour giving the support of IABP, urine output improves and patients start pouring the urine. And that actually causes the decrease in the CVP and decrease in the RV volume overload, and that will increase the chances of the RV recovery. So if after inotropes still there is low cardiac output state, instituting IABP for RV support will also help. And if everything fails, like if IABP, after IABP also low cardiac output state, then we call it severe RV primary graft dysfunction. And if the severe RV dysfunction happens in the OR when chest is open, then we have option of the putting the CentriMag. So RA, we can directly cannulate the RA, or we can go for the percutaneous femoral vein, and through femoral vein we can put the cannula which can drain the RA, and we can put the graft on the pulmonary artery and cannulate the pulmonary artery, and we can have RVAD. So CentriMag. So when chest is open, we have the option of the CentriMag. Now, if this patient is shifted to ICU and patient develops severe RV dysfunction in ICU, so if patient is unstable, then peripheral VA ECMO by the femoral vein and femoral artery, or we can shift the patient immediately into OR and can put the CentriMag or even ECMO. Or if patient is relatively stable, then we can shift the patient to cath lab and put the Protect Dio cannula or Impella RP and cause the RVAD. Then one small series of one study with the small patients, with 15 patients with severe PGD, they have suggested that 66% patient underwent the plasmapheresis significantly improved the outcomes after the primary graft dysfunction. And what they concluded, the depletion of the inflammatory molecules with plasmapheresis improves the outcome in PGD. But still, this is on the very primary level, and we cannot recommend plasmapheresis to each and every patient developing primary graft dysfunction. But yeah, it may help to decrease the PGD insult. In our experience, we had total 64 number of heart transplants. In that, mild PGD happens in 16 cases with zero mortality. Moderate PGD happens in 5 cases, again zero mortality. Severe PGD happens in 2 cases with 1 mortality. So take-home message is primary graft dysfunction incidence increases as we are using more and more marginal donor, and we are using more and more mechanical circulatory support as a bridge to transplant. So that's why PGD incidence has increased. Common risk factors for primary graft dysfunction, if we can prevent this, then definitely prevention is better than treating the PGD. So if recipients on MCS or high inotropes pre-transplant, it increases the risk of PGD. Recipients on amiodarone, if we use the undersized donor, like donor recipient PHM is less than like negative 30%, or ratio is less than 0.8, longer ischemia time more than 4 hours, and if there is perioperative excessive blood transfusion, these all are increased the risk factors for the PGD. Early IBP insertion when persistent low cardiac output with rising lactate even after optimization of inotropes, reload and vasopressors is the key. If patient is still in low cardiac output after IBP, then VA ECMO, we have to institute the MCS, and in MCS, VA ECMO is better over the VADs for severe PGD, and early and prompt ECMO initiation is better than the late ECMO initiation, and central VA ECMO better over the peripheral VA ECMO, especially when severe LV systolic dysfunction and patient is already in operating room. So thank you very much, and we are open for the questions.
Great. Thank you so much, Dr. Chintan and Dr. Meet. Wonderful presentation, Dr. Chintan. You really took us through the whole journey of PGD, explaining right from the basic pathophysiology to various management approaches, as well as later on what could we expect in the future. At this point, I think I'll invite Dr. Nagamalesh to help us take this discussion forward, and we'll rely on him to post some questions based on the case presentation. as well as the topic in general. And at the end, then we'll also go over any questions from the audience from the chat box. So, Dr. Nagamalesh, if you can hear us, we're ready to hear.
Yeah, I can hear. Thank you. It was an excellent presentation. I think you have explained a lot of things from the etiology to pathophysiology and the treatment. So I think this case, I just want to know what is the
Dr. Nagamalesh, your voice is a little muffled.
Yeah. So now, can you hear me?
Yes, better. Yeah.
Yeah. So about this case, I just want to know what is the post-transplant hemodynamics. I think that is not present there.
Sorry, what was the cause for the PGD?
Yeah, post-transplant hemodynamics.
Dr. Chintan, post-transplant hemodynamics, I think showed us everything except for the Swan-Ganz and what were the cardiac output, cardiac index, what were the PA pressures.
Yeah, so that patients, So that patients initially, when we have shifted the patient from the OR to ICU, cardiac index was around 2.4 to 2.5 liter per minute per meter square, and patient mean pressure was around 70 mmHg with some moderate inotropes. After 4 hours, then slowly patient started hypotension. And with that cardiac index, it decreased to 1.4 to 1.5 liter per minute square. Mean pressure was around 55 to 60 mm of Hg. And there was persistent acidosis and decreased bicarbonate.
What was the PVR and PA pressure and CVP, those things, post-transplant?
Sorry, I'm not able to hear clearly.
The pulmonary vascular resistance and the PA pressures and the CVP.
Post-transplant.
Yeah.
So initially when she was stable in the ICU, her CVP was around 10 to 11, and her PVR was 2.6 to 2.8 was there, her PVR at that time, with all inhaled nitric oxide, milrinone, and all the inotropes, optimized inotropes. And pressures, as I told, mean pressures around 50. Initially it was 70. When after 4 hours, it was decreased to 55 around mean pressure. And that time CVP had also gone up to around 1450, and PVR was around that time around 2 to 2.2.
Okay, so about the biopsy, any biopsy done? Early biopsy?
No, we have not done biopsy.
Okay.
Because this patient's LCM was negative. First of all, PRA was 00. LCM was negative. Donor-specific antibodies were negative. So, and we didn't suspect rejection, acute or any hyperactive rejection in this patient. And after initiating the IABP, patient started improving within like 8 to 10 hours. Patient started improving. So we just continued with the IABP, and ultimately in 2 days.
Your DSA negative or cross-match negative, you cannot predict whether this patient will be developing, rejection. So to tell you one incident I had I think 2 months back during our conference, we had one case, PRA is negative or cross-match was negative, and there is no primary graft dysfunction. When we did biopsy, we had a grade 3 rejection, and C4D is positive. In fact, I was also a little concerned. Even biopsy showed, even though it's not possible to have so early antibody-mediated rejection. So within a 1 week, we had antibody-mediated rejection, rejection. In fact, I discussed this with Sai Bangra from Papers and everyone. Even they also surprised having this type of picture. So what I'm trying to tell is we can predict rejection based on the pre-transplant dialogue. I hope what is the other panel?
Yeah, so I agree with that. Rejection can happen, but how we deal with it? Initially we optimize inotrope, then we put IABP, then we go on MCS. On MCS also, if there is no recovery for like 2-3 days, and patient remain in low cardiac output, said LV is not improving, then we should go ahead with the biopsy. But I think initially after 4-6 hours, if there is LV dysfunction, initial IABP, MCS, and then we can go for the biopsy to rule out any rejection.
So you have done first week biopsy.
Dr. Nagamalesh, unfortunately, your audio is still not very clear.
Yeah. What about first week biopsy?
First week biopsy, Dr. Chintan. When was your first biopsy that you did?
1 month. 1 month. So our biopsy protocol is 1 month, 3 months, 6 months, and 1 year. So we do 4 biopsy in 1 year.
Okay.
And in this patient, after 48 hours, her LV was normal, and then she didn't give any trouble. So we continued to follow our protocol, and we did her first biopsy after 1 year only. After 1 month only, sorry, at 1 month.
Hi, Tala.
Yes, sir.
Can I ask something?
Yeah. Yes, sir. Sure.
Was there incidence of first one was hypertrophic cardiomyopathy in the donor? Secondly, EHM was also very high. Thirdly, the third question rather I would like to ask is in case of primary dysfunction, when you do the echo and realize that the LV and RV are struggling, or LV or IRV are struggling, and you are optimizing the inotropes, that time when you do echo, many times you see a myocardial edema. And in that case, have you tried keeping the chest open option? Because it not only helps in reducing after 4-5 hours of problem in ICU, but also if it happens, it is very fast to put the central mechanical circulatory support in these patients.
Agree, sir.
Tala, are you saying that you have to keep the centriback standby?
So, no, sir, I think what was discussed was that we don't prefer using, Centromag as a ventricular assist device, but maybe if you're using Centromag as an ECMO, yes. So, definitely, I think if you are entertaining any grade of PGD, definitely some kind of MCS should definitely be on standby. I think the question that Dr. Mule was trying to pose was, you had mentioned that low PHM, donor to recipient, low PHM ratio is a risk factor for PGD, but is a high PHM ratio, is that also a risk factor?
Yeah, so as per the ISHLT guidelines, donor to recipient PHM ratio 0.8 to 1.2 is the best. It's optimal. Okay. In this patient, it was 1.48. But up to 2, donor recipient ratio, up to 2, we can accept the donor. And in this patient, when her PVR was initially to start with, it was 5 point something. And after Mildron bolus and after infusion of Mildron levosimendan, and after optimizing everything, then only her PVR become less than 3. So in such case, I would like to use little oversized donor.
Yeah, no. See, listen, my question was totally different. What I'm asking is that when you are waiting for optimization of your LV and RV by inotropes, when you see while coming off bypass first time, your LV or RV or both are struggling, correct? So that time you do an echocardiography. Have you noticed a myocardial edema in these patients?
No, we have not noticed myocardial edema.
So
we have not noticed any.
We have often seen that. In that case, keeping the chest open and not closing the chest.
Yes.
Sometimes helps in avoiding after 4 hours, what you experience, that possibility of avoiding is 50%. And if at all it happens, putting the ECMO or mechanical circuit support is very easy because chest is open, you can do it immediately there.
Agree, sir. Yes, sir.
I have just question to Dr. Mule.
Yes.
See, Dhaval here. How are you, sir? All well?
Good. I think so.
Basically, actually, it is all big hearts actually in the recipient.
Correct.
And the pericardial cavity is too large actually. Whatever you put inside, you have a lot of space.
Yeah, it is not every time. So
what we do in routine, cardiac surgery, we notice myocardial edema in a small pericardial cavity, and sometimes we open the chest, we keep open the chest, and we just wait for the edema to subside. That is okay. But I don't think this is now debate actually. I don't know whether it is feasible or it is a good option actually, or a good things to keep the chest open. When we have a big pericardial cavity, your heart is too small actually, which is easily accommodated in that. Even if it is a myocardial edema, it could accommodate actually. And if at all we have to put ECMO, central ECMO, that is what is only concern. Okay, then I think it doesn't make any it takes time actually to open the chest and to do that.
I think you missed the point.
This is what we feel actually.
I think what I said is that if you notice myocardial edema too much,
but then the pericardial cavity is too big actually.
Not every time. It's not every time. And when you put the heart, sometimes it occupies quite a bit. So when it can accommodate, but when you close the chest, the hemodynamics is different. When you keep the open, it is. I'm just asking the possibility. And 50% of the times, 50%, not every time, 50% of the times, you may be able to avoid the MCS, or the recovery is much better, faster, and next day you can close the chest in ICU. Anyway, that's one of the options.
You must be you must be familiar.
No, I'm not familiar. I hardly keep.
No. We do it very oftenly with some sick cases in routine regular cardiac surgery. But you must be you're more experienced actually. So
no, it is not experience.
We never open the chest.
I'm discussing Dhawal. I'm not saying that it is the only way. I'm saying that there is one option also can be remembered and kept in mind.
Okay. That's an option. Okay.
So why I didn't say the PGD is what? PGD means that there is no definite, there is no rejection, there is no infection, there is no sepsis, there is no PVR. Everything is normal. But still, why me? Why this heart is not functioning? Why it is LV or RV dysfunction? And we don't know the cause. When there is no cause, we call it primary graft dysfunction.
Yeah. We had 9 years before, actually, that's our second heart transplant. We had the same experience. After transplant, the heart didn't start actually properly. So at that time, in theater itself, we initiated central ECMO. We just take out the aortic cannula from the suprasternal notch, and the IVC RA cannula from the sub-Ziffy space, and we close the chest, just fear of the bleeding actually. That way we managed for 5 days. Fortunately, that patient came out from things. The heart started working. But that is but I agree with you. As a surgeon, we have to keep all options open actually. That's what I can understand, I believe.
All right. Thank you so much, Dr. Dhawal and Dr. Mulay sir, contributing towards the discussion. Just taking the discussion towards to a different direction. Dr. Chintan, in your team's experience, do you use or what's the role of additional cardioplegia? When you are expecting that the ischemic time is going to run up higher, and is there any data to suggest that additional cardioplegia helps?
So our center's protocol, whenever we expect ischemic time is going to be more than 4 hours, we repeat one cardioplegia. When heart comes to us, we repeat one cardioplegia. Recently we got the heart from the Jabalpur, and we knew it already took 3 hours for the transport, 2.5 hours for the transport. We knew it will take more than 4 hours total ischemia time. In that case, we repeat. So it's a protocol. Anytime expecting more than 4 hours, we repeat cardioplegia. And it worked well for us.
Also, there are a couple of questions in the chat box. One of them, I think you would be the best person to answer. Could you please explain as to how low PEEP and low tidal volume is RV friendly?
Yeah. So tidal volume should be like 8 ml per kg or maybe 6 ml per kg, and PEEP should be 5.
No, but how is that RV friendly? How keeping a low tidal
So
volume?
it prevents a decrease. It prevents the increase in the RV afterward. If we give high tidal volume, if peak inspirator pressures are high, if PEEP is high, it increases the RV afterload. So as already RV is failed at dysfunction, increasing afterload further damage the RV. So if we keep the peak inspirator pressures lower, so increasing PEEP or increasing tidal volume ultimately increase the peak inspirator pressure. And if you can maintain it at a lower level, it will help to decrease the RV afterload.
But will not that increase your CO2?
No, so we can increase the respiratory rate. So with low tidal volume, if like it's like ARDS, we do the lung protective ventilator strategy in which we keep the tidal volume 68 ml per kg, and we increase the respiratory rate. Instead, generally we keep 12 to 14. Here we can 20 to 22. So according to the ABG blood gas and according to PSO2, we can increase the rate of the respiratory rate instead of increasing much going on the tidal volume.
Okay, great. Thanks. Just one more question, more from a medical aspect and more from recipient factors. We mentioned about presence of quadron being one of the risk factors. Going along the same lines, how about ARNI? Have you noticed patients being on, high doses of ARNI that correlate with PGD?
So 50% of the recipients are on ARNI when they come to the transplant. And out of that 50% develop severe vasodilatation initially for first 24 to 48 hours. We know that we expect, because as we all know, AC inhibitors and ARBs and this sacubitril and this definitely will cause the vasodilatation. And we monitor the SVRI, systemic vascular resistance index. Normal is 1900 to 2300. So if SVRI is low, our first preference of the vasopressin is vasopressin, as I mentioned. And when vasopressin goes more than 2 units per hour, generally in adult 60 kg of the patient, then we add the noradrenaline into that patient. And we try to maintain the SVR around 1900 to 2000. So we expect vasodilatation, even severe vasoplegia also associated with use of the ARNI.
So do you as a protocol try to discontinue patients ARNI while they are on the wait list?
No.
Dr. Aditya, I would like to hear your team's experience as well. I noted Dr. Julius is also there. I know he has an opinion about ARNI in advanced heart failure as well. So I'd be eager to know your views. I think we have about another 4-5 minutes more for discussion.
Sure. Thank you for bringing up that point. So first, for the benefit of the audience and everyone, we should clarify that post-transplant or post-operative vasoplegia is different from PGD. So vasoplegic state, vasodilatory shock, significant vasoplegia that can be related to ARNI, but that is separate from PGD. The definition of PGD itself says under normal loading conditions, you have poor contractility, low cardiac output state. So that implies that the SVR is normal. So definitely you can have post-op vasoplegia, but it should not impair the contractility per se. In a vasoplegic state, you should actually have hyperdynamic contractility. So coming to the point of ARNI causing vasoplegia post-operatively, yes, there have been several cases of this as well. And generally, we stop ARNI on all our patients that are waitlisted. Even in the US, when I was practicing, all our heart failure patients, VAD patients, we used to stop the ARNI once they're waitlisted for heart transplant. The incidence of vasoplegia is more with ARNI compared to ACE inhibitor or ARB. And additionally, it doesn't really serve a purpose also for these heart failure patients once you've already decided that they have advanced heart failure. So there is no morbidity or mortality benefit at that point anyway. So we do stop this medication for all our waitlisted patients.
Aditi, do you feel sometimes it is difficult to manage without see, if they tolerate, it's fine. But most of them, those who are army stop, they start deteriorating and they start coming back with heart failure. So do you feel that, what we do is when we come to know there's a donor, we'll ask them not to take rather than stop indefinitely, because sometimes you get donor after 6 months, after 1 year. You don't know when they get. So I feel it's difficult to stop medication when we listed them. Rather, you stop it when you come to know that you are planning to do it next 24 hours. So the two doses can be stopped. I know it's difficult to manage post-op. You need to give vasopressors and all this. You try to manage rather than stopping and getting into problem with us.
Tell me, what stage of heart failure is Arni indicated?
I know that. So, in the advanced heart failure, you don't require army. But those who are on army, if they have developed advanced heart failure, withdrawing is difficult. I don't start army for advanced heart failure. But majority of them come to me with army, they are advanced. So there it is difficult to wean army.
We look at it the other way.
Exactly like a digoxin. Their many trials showed that yes, digoxin is not good, but their patient is already on digoxin. You withdraw digoxin and they will come back with heart failure. So that is the guideline. So you cannot stop digoxin, but don't start digoxin.
So I agree with that point, Dr. Nagamalesh. There are patients with heart failure who have been on an ARNI for a long time and they do feel worse once you stop the ARNI. So it should be a more personalized approach. Most of the cases that we end up seeing, they're very hypotensive and they're not tolerating ARNI already.
But the different subset.
Yeah, if somebody is tolerating full dose ARNI, they're probably not in the transplant category yet.
No, sir. See, full dose ARNI 200 mg very rare to tolerate at advanced heart failure. Majority of them will be 50 mg BDR, 50 mg half PD. Those who are advanced heart failure because they can't tolerate so much beta blocker or ACE inhibitors. So I'm not telling you for 200 mg BD. So most of them are 50 mg BDR half PD.
Yeah, these two, three things I tried to stop. One is ARNI, the other one is amiodarone if possible, or at least minimize the dose. And the third thing is NOACs. We put them on warfarin. I don't mind warfarin at all. But I do have a problem with NOACs.
And also clopidogrel. If you have clopidogrel, you can just convert them to aspirin.
What about SGLT2 inhibitors? Your DAPA?
SGLT2 is stopped because, the day of transplant will come with urinary tract infection. So you will be in trouble. So I stopped SGLT2 and try to keep ARNI and beta blockers if they are tolerant.
Got it. So I think the takeaway message from today's discussion is that in terms of primary graft dysfunction, it's definitely easier to prevent than to actually manage PGD. However, given the best centers with the largest volumes, the mortality rates are still pretty high for severe primary graft dysfunction, approximately 20 to 30% as per some studies. So always good to prevent it. So whatever we can do to prevent it from a recipient perspective, from a donor perspective, I think that and whatever is in our hands to modify those risk factors, we can definitely do. I think that basically concludes our webinar. We've just crossed 8 p.m. If there are any additional questions, I see some in the chat box. I or Dr. Aditi or Dr. Nagamalesh will try to address that right after. Thank you once again, Dr. Chintan, Dr. Meet, and Dr. Nagamalesh to take out time bang in the middle of the week in the midst of your busy schedule to contribute towards this. Hopefully, we can have many more webinars over the next year like this and basically expand on our knowledge and learn from each other. Thank you once again, Dr. Chintan.
Thank you very much.
Thank you. Excellent case. Thank you. Any closing remarks from Dr. Durairaj and Dr. Jabir? There are senior leadership from SfHFT.
Do you hear me at all? You hear me?
Yes, we can hear you, Dr. Durairaj.
So much. No, can't. Okay, I think
Very dodgy. So I think what we'll do is I'll take the liberty of ending the webinar. Thank you again. Thank you. There's a backstop working on behalf of SfHFT in trying to get these webinar invites out and making sure that the webinars work technically fine. Thank you so much.
Thank you very much. Thank you.